Thank you for joining today's Health, Education, and Learning Program webinar, Making the ACO Decision, How to Select an ACO. By attending this webinar, participants will identify variables to be considered when choosing an ACO, compare the various financial models offered by ACOs, recognize suitable questions to ask prior to joining an ACO. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. As the nation's leading technical assistance and knowledge center in rural health, the center focuses on 5 core areas: transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. The center is committed to DEI and anti-racism, and we create an environment that reflects the communities that we live and serve, where everyone feels accepted and empowered to be their full, authentic selves, and where everyone belongs. We understand the impact and seek to defeat racism and discrimination in ourselves, our workplace, and the world. And this guides how we cultivate leaders, build our programs and resources, and deliver our technical assistance. We are an organization that honors, celebrates, and respects all dimensions of diversity. And these principles are central to our mission and to our impact. With that being shared, I'd like to welcome our guest speaker, Ralph Llewellyn. Ralph is the partner in charge of critical access hospitals with iBailey. His office is located in Fargo, North Dakota. And his career started as a rural hospital CFO. For the past 24 years, he has been with iBailey, where he is a leader in the healthcare consulting practice. He assists providers of all types in the development of strategies for improving financial performance and maintaining compliance with healthcare rules and regulations. He leads financial and operational performance enhancement projects, charge master and cost report audits, reimbursement enhancement studies, and also assists in the development of physician compensation strategies. Ralph is a frequent speaker at state, regional, and national healthcare conferences. We're pleased to have you, Ralph, and thank you for joining us. And I'm going to turn it over to you.
All right. Well, thank you very much. Greatly appreciate the opportunity. A little bit about my background. My name is Ralph Llewellyn, and I am a partner in charge of critical access hospital services for iBailey. I'm based out of Fargo, North Dakota, so I am still enjoying great cold levels. Hopefully some of you are in warmer areas. By background, my start in healthcare was back in '91, and I started out as a small rural hospital CFO. Back at that time, a 49-bed hospital, because almost every rural hospital was a 49-bed. They're a critical access hospital now. 116-bed nursing home. I'm a licensed nursing home administrator with background in that area. We were pretty much the typical type of rural provider. Had a hospital, had swing bed, had the nursing home clinics, home health, assisted livings, the types of things that you would expect to see in a lot of different facilities. For the last over almost 25 now years, I've spent most of my time in rural America working from this side of the fence, helping providers in the area of reimbursement operations and other pieces along the way. My background in the ACO movement is, really got engaged when the AIM funding came out, now almost, 8-9 years ago. And that was part of being with some of the big ACOs that were set up in the rural setting. Initially, we were working as a financial advisor in those initial AIM-funded ACOs for 54 different rural providers. And so those were rural providers in a mix of states across the country, mostly I think the Mississippi and West, but rural in nature, very early in the process. At a time when I'd say people were still learning. A lot of learning going on then, a lot of unknowns and a lot of questions and concerns. So today's topic, we're going to talk about how do you choose an ACO. And so I'll share kind of what we've seen and felt over the years as we look at this model. This is going to assume that a decision has been made that you're probably going to be looking for an ACO. So we're not going to talk about how you get there and why people do it. Typically facilities get into it, because they have a passion for population health, or they have a desire for potential shared savings, which, we've been fortunate enough with the ACO participants we've worked with to see some decent shared savings amounts over the years. And some providers have really figured out and understand how to capitalize on this model to build volumes, which is a little counterintuitive aspect that we think if we're going to save cost, drive down cost of care, that's going to be lower volumes. But in all actuality, in the rural setting, sometimes by doing this it's a shift of where the dollars are spent. And it provides an opportunity for facilities to actually enhance their volumes and their presence, either through wellness and preventative services that they're billing for. Because when a lot of the savings come elsewhere, they don't come at that primary care level, that smaller facility level. They come in from things like pharmaceutical savings over time, preventing services out of large brick and mortar entities. A lot of the slicing, dicing kind of things I call it, where there's big fees related. It's doing that prevention work. And oftentimes we can build our awareness, and through our awareness, we can actually build some increased market share. So a lot of the facilities I've worked with over time have seen an increased market share through the involvement. So let's just start making sure everybody's on a level spot as to what is an ACO, what's it set up like. I like this first term here. It's a mechanism to monetize value by increasing quality and reducing costs. And I think that monetizing value is the key term here. Prior to this model, if you did things right and you drove down cost, you reduced the services that were needed, your reward was less revenue. There wasn't the necessarily upside financially, which you have the holistic side of I need to take care of patients, I want to make them better, but if I do it too good, I lose the revenue stream. And so you had challenges. This kind of fixes some of that in the right setup. It's a group of healthcare providers that come together voluntarily to coordinate high quality care to their patients. And I would underline voluntary, because it's voluntary today, but I think at some point in time, and we're getting closer to that, it's almost going to be a cost of entry. If you're going to be in the healthcare industry, you're going to be forced somehow through, or pressured through payment methodologies, incentives or disincentives to get engaged in these models. And so I've always been a big fan of those that got into this earlier, because there's a lot more ability to learn. The processes and the programming was a lot more forgiving at that point in time. And the goal of this is coordinated care to ensure that people get the right care at the right time. That all seems to make sense, while avoiding unnecessary duplication of services and preventing medical errors. So that kind of gives us the baseline of what we're looking at here. When we look at the types of ACOs and other things around them, they're typically hospital or physician-led. The majority that I've seen in rural America have been hospital-led, not seeing as many physician-led. You start to see that when you get into the bigger metropolitan areas. You end up getting assignment. You get assignment of your population that you're responsible for through primary care physician assignment. It's based on the amount of primary care you provide versus what others are providing for that individual. And the whole target here is if costs are lower than the target that's established, savings above a certain amount can be shared between the providers and the payer. And so Medicare being the first one, there's a lot of 50-50s initially. There's other models that have different percentages, but it's really getting to that target piece. And so it's not just the costs that are spent at your hospital or in your entity, your clinic, or your practice. It's what's being saved in the totality. So there's a lot, and we'll talk about it a little bit as far as when you choosing an ACO and who to work with. What you really want to find out is who's got the data and information to help you understand where all the expenses are being incurred, how much, by whom, in what settings, all of those typically types of things. The one nice key piece, I think, from a individual who's seeking care is that quality has to be demonstrated. So this isn't about just rationing care. This is having to make sure that we're pulling out costs in the right areas. So we're spending money in the right area, creating savings in other areas that are the right areas. But at the end of the day, we still have to demonstrate quality. So there's quality reporting around these things. $5,000 lives minimum is typically what we're going to see. We've seen them. I've seen them from 5,000, or mostly about 10,000. all the way up to over 100,000 lives. Even those that are in small rural areas, they're tied into a bigger group, a bigger network, so they can get up to those numbers. And it started with one-sided models meaning there wasn't a downside or a risk factor from the aspect that if costs went up, you weren't penalized. You could get savings if a certain amount of savings was achieved. But this is definitely moving to two-sided. Probably not as fast as a lot of payers and individuals would like to see, but not as slow as providers would like to see. But definitely there is some continued movement and push to a model that is two-sided, which means there is potential for upside as well as downside, meaning if costs go up, you may be on the hook for part of that cost increase. And so that's another thing that you kind of think about when you look at which model of an ACO you go into within the ACO groups or entity or the aggregator that you choose. As far as payers, this can spread across all kinds of different payers. Historically, when we first saw this rolling out, it was around Medicare. And so we had the Medicare ACOs, the MSSP, we have Medicaid. Within Medicaid, it could be a state-ran program. It could be something that's actually tied in through commercial payers that are helping with that managed care. And then there's commercial that are out there. And the one thing I would say in this area that we got to keep in mind is that what we see today is only going to continue to grow. As costs continue to be a challenge for the individual patients and the payers and the government, there's going to continue to be a push to looking at some sort of value-based model and how we can best decrease costs over time in the long haul. So the ACO consideration, setting up an ACO. When I initially talked to individuals that are looking at an ACO, that whole model, typically what I'll hear from a lot of providers is, they only see a downside to the successful implementation. If they're going to do it right, it's going to be a lot of investment. A lot of investment in time. If you look at, and I remember when they were first setting up some of these ACOs, there's a lot of legal work that goes into it, a lot of, creation, negotiation, things like that there that take time as well as money. And so, really the solutions out there, the answers is not really setting it up yourself. It's finding somebody who's already has the ACO. So it's looking to external resources, looking to aggregators. The aggregators are the ones that bring a lot of different individuals together. We've seen a couple of really successful ones in the country, both nationally as well as regionally, where they take facilities and entities that aren't even related in any way, shape, or form and bring them together. And so they're able to help take care of that issue of, that whole piece of investment of time and money and take that off of the plate to a certain extent to the individual facilities. The other thing when they look at the successful implementation of a population health strategy, again, facilities, as I mentioned earlier, are concerned about that issue that if costs are going to go down, that means I'm going to have less revenue. I'm struggling to make it today. The ones that are doing really well in the conversations we have in trying to encourage people to consider this is looking at how you can increase the amount of local services. And so when you start looking at annual wellness visits and preventative care and things like that there, it's trying to maybe increase the number of services an individual is getting locally, but not in total. So we're doing things locally, we're doing them on a preventive basis versus them going external or going on a after the fact, after the accident, after the issue comes up. And really trying to build that volume by getting more people encouraged. I think of things like annual wellness visits. I've heard stories of folks using that as a conduit to having good PR in the community because people start to hear about, annual wellness visits and the positive things that come out of that with early detection. We think about chronic care management. We think about people, hearing that their local nurse or providers is holding their hand during the month, spending some time with them and helping them make sure they're getting the care they need back to that, the right time, at the right place and all of that. So the question I get oftentimes is, are all ACOs created the same? And the short answer is no. When we look at the various ACOs and the aggregators and all those out there, um, there are all kinds of shapes and sizes. So, there are new ones. There's emerging ones that are coming out, and we're hearing about, smaller regional groups trying to pull together and start things. There's nothing good or bad about being new versus old, but new ones just learning still. You got to look at a little bit of what's the experience of the individuals in that kind of a model. We have older ones, those that have been into this, around 10 years. The more experience. Now, more experience doesn't necessarily mean better. It doesn't mean worse. It just means more experienced. They may have created some really great tools. They may have not created great tools. There are larger ones, some that are over 100,000 lives, and some of these even with rural providers engaged. But there's also smaller ones. A lot of what we saw initially were smaller little subgroups. And now we've seen them start to group together and build up bigger bases. As you build base, you reduce the overall risk of variation. You can sometimes get better incentives, better opportunities in that range. And there are national ones. We think about, there's a few big names that we hear quite often. So there's big national ones. National ones are nice because they show you experiences across the country, but they may not be focused on a specific community or a certain region as tightly. There are regional ones. I think of I've a couple of them in like Western United States. There's a couple of regional ones that we've worked with over time. And then there's state ones. I think of the state ones, a very common one you hear about is like ICANN. That's in Illinois. Very focused on a specific state. Pros and cons and all kinds of things, but they're all a little different, made up a little differently. There are what I'd call full service aggregators and ACOs. Full service meaning is that they give you a lot of tools. They give you a lot of experience. We'll talk about some of those tools. Sometimes those tools are embedded in a fee. Sometimes they're not. Sometimes there's a lot of a la carte, where everything that you want is separate. It may be a separate fee, a separate arrangement, separate setup. And then there can be even these hybrids where it's full service to a certain point, but anything extra you want above that is a la carte, and you kind of look at that. There's also what I would say expensive ACO models. And then there's also ones out there that we see that I would say are less expensive. And, the price point being expensive or inexpensive may or may not be related to the quality, may not be related to the results or the services that you get. It's just that some are more expensive and some are less expensive. So that's part of what you look at when you go out and start looking at, how do you choose one? How do you come up with what you want? I think the most important piece is that within these models, facilities can either make them work or they can fail. So it's not as much about the size, the shape, in that it really comes down to more the people, the individual processes that are embedded, the history, the experiences that they've learned, the things that they bring to the table, on both sides. Sometimes I've seen great ACOs that have just had bad facilities get engaged. They sign up and they just think everything's going to happen on its own. So you can even find the right place and still not make it work because you don't have the internal buy-in. You don't have the internal processes moving and going forward there. So it seems to me that a lot of times when we start up these models, you can seems you can tell pretty quickly if they're going to be the right fit or not. The thing is, you got to realize is that a good one sometimes can become bad over time, and ones that aren't as good can become a lot better over time too. So, we've seen some that have bounced from one ACO to another over time, just because their needs changed, their expectation changed, and their opportunities changed. So, what do you start looking at? What are the factors you got to look at You know, what might be a good or a bad thing for something. You know, a lot of it is looking, you know, starting to look at locality. Locality is important to some people and it's not important to others. I would say pre-COVID, um, locality was probably a little bit more important, but we've all learned to work remote and that's changed our models. So maybe that's not as big of an issue anymore, but a lot of times people look for headquarters. If I'm on the western part of the country, do I want to work with something that's headquartered out of the eastern part of the country? That may or may not be a big issue to you. You know, where's the headquarters? Do they have regional staffing? You know, I might be more comfortable if it's got regional staffing, but I still, you know, I want something that feels like it's closer. Even if they're all working remotely, I want something that where people seem to be headquartered or living closer to my area, maybe feels like it works better for me. They have a better understanding of my region. Other thing is, you know, looking at, you know, other participants, you know, who else is in this ACO that I'm looking at? And this one's interesting from the aspect that, you know, do you want people that are participating that are local, or does that concern you? And I see facilities having different opinions on that. And, you know, I think it's just something you gotta think about and work through in your organization. Um, some people feel like if they have too many locals, it's basically their competition. So they're learning from their competition, they're sharing with their competition, and that just doesn't feel comfortable to them. Others work very collaboratively with their competition in other areas. They feel very comfortable. They want participants that are local in their same state, in their same region. Again, at the same time, others want people that are very far apart. Not a right or a wrong. It's more about what is it you're looking for. Your competitive dynamics historically can sometimes drive it. You know, I can understand, truly understand if it's two facilities in the same community. Obviously, if we're working rural and CAHs a lot, we don't see that often. But if you had two in the same community, I can understand not maybe wanting to have that much closeness. But you know, in a state like me in North Dakota, you know, having 5 or 6 facilities in the state of North Dakota working together in different areas, that's probably close enough, but not too close. There's just a variety of opinions there. You also have to look at status of system affiliation. Um, you know, being in a system may limit your options out there. A lot of times systems have developed their own ACOs, their own methodologies, their own models. And so that may limit your ability to look at another option out there. Um, and so something to think about in that arena. Whereas if you're independent, you may have more options out there as far as different types of ones. In some markets, you may have less. It's going to all vary depending on the individual market. The size of the ACO. You know, do you want large or do you want small? And this one's interesting too, because initially when I started working in the ACO models and they were rural settings, they were ACOs of, you know, 4 to 8 facilities. And they got up to their 5,000 lives. So there are a lot of 5 to 10,000 live kind of ACOs. And everybody felt good about that there because it was smaller. Now, they were smaller facilities jumping into a smaller, you know, ACO. But as they got moving forward and they started to learn about the processes and their thought processes matured, their abilities matured, the whole concept matured, they opted and pushed to go into larger ACOs, mostly because sometimes the barriers to be able to get savings were smaller. The ability to control risk in a larger database is oftentimes easier. So, you know, you may start out saying, I want to be part of something small so I can learn and be smart, part of a small group, but at some point I may want to graduate. At the flip side, you might start really large and find out that's not for you. And so I haven't seen as much of that. The ones that have went into the larger ones have historically, for the ones I've seen, stuck in that model. But that's not a right or wrong. That's going to be a facility specific kind of conversation about what works and, you know, what doesn't work for an individual entity. Again, you know, then it's, you know, who are the participants when you're looking at these factors? You know, I talked about locality, but you may also be looking at, you know, Is it for profits and we're a nonprofit? Do we feel like that's, we got the same vision, the same mission, the same, play that we're trying to do here? Is it clinics, or is it focused on clinics and we're a hospital and we want to work with others that are in hospital based? Or is it all hospitals and we're a clinic and we want to work with one that's more led and directed from a clinic perspective? Is it freestanding entities, imaging services, things like that? Who's all playing in this bucket? And are we going to be similar enough that we're going to work well together, but different enough that we can learn from each other? What's provided as far as, through your participation. And this is something that, we've really saw a lot of growth in the last couple of years. Is, what do you get with being part of the ACO? Is it just like, well, here you go, you've signed up, here's your signed lives, you figure out how to, start driving some savings? Or is it more robust? And so we're seeing a lot of population health training that's provided, nursing training, clinician training. A lot of times these might be done through some cohorts, they might be done live, they might be done through webinar, they might be done recordings, all kinds of different ways to learn. Data tools. From my perspective, when I first got engaged in ACOs, I thought one of the best benefits was all this data you got, because you can typically get all of the claims data for the people that are assigned to you for the services they receive, regardless of where they go. If it's you or if it's somebody else, you get access to that. And so initially, early on, I would say the data services were pretty clunky, meaning there was a lot of data, but there was nothing that was really well refined out of that data. And so that's been some of the maturing that we've seen. Board training, analytics training. The analytics training kind of goes back to the data. Once you get the data, is there training to say, here's how you should look at the data. Here's what you can learn from the data. This is what it's telling you. This is how you can build strategies. How do you start trying to find out, which provider provides the best results? If I send people to provider A versus provider B, can I figure out which one over time seems to deliver the best quality and cost combination? Sometimes we find out that the one that we always thought was the best provider ended up being a high cost provider, maybe didn't deliver the quality. But we can get that through the services, the data, the information that's there. Do they have reimbursement expertise? I think we found that with especially critical access hospitals when they were first getting into ACOs, is there wasn't a lot of depth out there as far as individuals that were in the population health side that understood what changes were being made in an organization and how that might affect cost-based reimbursement, right, wrong, or indifferent, but just getting that data and understanding that. Billing expertise. Early on, we saw, and I still see, a lot of ACO vendors out there that will provide guidance on billing and how to do it and how to get paid and things like that, that are errant, non-compliant, very concerning. Some of them are very good and provide very good data, very good information, provide very good support, documentation, copies of rules and regs that say, here's how you do it and why, all of that. But there's just a lot of different services out there that you can get from some ACOs. In others, it's going to be much more limited. And it's not a good, bad, or indifferent as far as how much you want to get. It's just an understanding when you're making this purchase or this acquisition into an ACO, do you know what your money is buying or what your risk is buying and all of that? Other things, what other services are available above and beyond the normal contracting? I've seen some that have help with, 340B. It's not so much it's a cost savings piece. It's just making sure you're capturing all your eligible 340B stuff. What extra comes into this? Is it an extra dollar amount? Is it just built in? How's that work? The other things you want to look at is, how are savings shared? Is it, because it's not typically just back to your facility, the savings back to your facility. It's because it goes back to what's the whole ACO doing. And so we're typically, since we're aggregating, we got to look at how we're going to save that or share that aggregation of savings. Oftentimes the things that we'll see there are things around things like volume. The more that, the more attributed lives you have, you get a bigger chunk of the savings. Now, it may not be 100% that way. There can be mixes. It may be based on quality. How well did you do in the quality reporting compared to others? So there might be some certain tiers or milestones that you have to hit to get there. Other milestones might be things like participation, in education and things like that, or other types of projects or initiatives that might get you the ability to earn a bigger share of that total savings amount, because the savings aren't being shared equally amongst everybody, just one facility to the next facility the same. The other piece is when you're working with an aggregator or somebody who's building this piece, is how much are they taking? How does savings get shared with them, or does it at all? Maybe there's fees that are set up on the front end, so there is no savings going to them. But there may, and typically is, some sort of potential for them, if they can help get everybody lined up, get them performing in the right direction. There's also some potential for there to be some savings that goes to them also. So let's talk about some of the financial models and how we see people tied in with these ACOs. Obviously, there's the risk sharing and the non-risk sharing, one side, two side financial models. I'm not going to spend a lot of time there. What I'll tell you is that early on, if you're dabbling and just jumping in, you really want to start probably with the least amount of risk, a one-sided if you can get in. There's new rules and things along the way from Medicare and other payers that are starting to limit some of that. Two-sided models are for the more experienced. And so time will tell when you're ready to do that. You'll be able to, if you're in an ACO that's doing a good job of demonstrating success, and you've been able to do that together as a team, you got the team model working, that's when you want to start looking at those models. But there's also the financial models about how do you pay for this service? How do you build this ACO? And so originally, what we saw was mostly, an assigned amount per beneficiary per month, be it $5, $10, $15, whatever that amount was, it was so much per month. And within that model, there may or may not have been caps. So if you were an extremely large one, you could be paying that fee on every one of those beneficiaries. If you're small, you're not paying many dollars on that. The larger organizations oftentimes are trying to push back at that, saying, wait a minute, at some point in time, there's not incremental costs that makes sense to have the same dollar amount on every beneficiary. So within that, you may or may not have scales, meaning from 0 to 1,000 lives, it's X dollars per beneficiary. If you start going over 1,000, it's got another level. Then there's another step and you get a little higher. There's a little bit of those kind of models that we saw early on. Sometimes there may be a base fee. So just to get in, it's X number of dollars a month and then so much per beneficiary. It's kind of a mix between a per beneficiary and just a set base fee. So it has a little bit of a scale built into it. And then within those models, there may or may not be a take on the, take of the cut on shared savings. And so, back then what we would have a lot of conversation around is how many dollars were the aggregators or those entities asking for on the front end, kind of their guaranteed payment versus how much risk were they taking trying to get shared savings. So if they were going really low on a per assigned beneficiary to attract volume, they might be trying to take a bigger piece of the savings. Or it could be the other way around, they're taking a lot of dollars on the front end, but then they don't get as much shared savings on the back end. And so you got to start thinking about, well, what are the right incentives? What makes the most sense? What's the total cost? Oftentimes for providers, you can probably imagine, very attractive to have low fees in the front end. It looks like it's cheaper, even though in the long run, oftentimes it's a lot more expensive. Heavy focus on training, best practices, especially training at the beginning, because a lot of best practices weren't known, but definitely there are some real best practices out there. Data initially was very raw. I'd say very unrefined. Sometimes it was just basically data dumps, in my opinion. A lot of times that was because who was initially creating that data. A lot of times it was just data geeks. They're able to come up with a ton of data, but it wasn't necessarily anything that was in a good usable format. People hadn't learned, the industry hadn't learned how to really use that. Analytics, some are really strong, some are extremely weak. You could really quickly tell who understood healthcare and who didn't in the tools that they had in this area. Today, we're still seeing some per assigned beneficiary volumes. And so you get these per beneficiary per month. But we're seeing a larger growth in low or no fee, which to me is really interesting. The experienced aggregators seem to be pushing more towards a no fee. Hey, come join us. We'll take you in. We're gonna give you all the tools. We're gonna give you all the pieces, and because you have no cost, it's no cost to you. We'll just take a larger cut. Now they don't tell you they're taking a larger cut, but if you've been watching these models over the years, the amount of cut they're taking is much larger than what it used to be. So that's kind of the model that they're looking at is you can get in, it feels no risk. And if you're in a two-sided model, they may even provide you some protection from shared losses. Now, again, if you go down that model, they're even going to take a larger cut. Because at the end of the day, they're going to get their money somewhere. They've got that figured out. And they kind of work down that direction. There's a heavy focus on training and best practices. A lot of times this is focused in the group settings and not as much individualized. Early on, it seemed like there was a lot more individualized training. So that's something you want to consider when you're looking at an ACO partner is, how much of this is, definitely a group training versus an individual. If you're newer, individual is just a lot better, I think. Maybe extra services. The access to data is definitely increased. It's not just raw all the time, although I still see some of that. And the analytics have grown substantially. Some of them that I've looked at, some of their analytic tools, I can really quickly drill down to where there's opportunities, where there's high cost providers, where there's low quality providers, where there are, high cost individuals. And a high cost individual identification isn't saying that that's a bad individual to have in your practice. It just says you maybe have somebody who's got a bigger opportunity. And you start looking at certain types of conditions. Why are certain conditions much higher cost in our group versus maybe others in our ACO, other facilities? A lot of things you can do with the data. At the end of the day, there is definitely some real, you get what you pay for. Some of the proposals, some of the models I've seen, and some ACOs have multiple types of proposals. Some of them really try to make it look like they're really inexpensive. And the one thing I'll tell you is anybody can compete on price. It doesn't always drive the quality. And so you want a good balance there. But sometimes you give up a payment or an expenditure on the front end, but you pay for it a lot more when you get to that shared savings and things like that, which again, a lot of our facilities we've worked with have seen shared savings. So a lot of it goes into, how much risk are you willing to take? How much are you willing to spend the dollar today, hoping you get some shared savings? Or don't you want to spend any dollars today? And if there's shared savings, you'll take a smaller piece. Again, there's not a right or wrong. Everybody's financial situation, condition is a little different. And so you got to figure out what makes the most sense for you. On the flip side, how much reward are you willing to give away? If you're not gonna pay for anything and you're gonna have them take the risk away of any downside because you're in a two-sided model, you're probably not gonna have an opportunity for much upside. So you got to look at all those things. And again, like I noted earlier with some of the other things, any model can work or fail. It really comes down to what's the amount. How much are they charging? How much are they taking? How much are they giving? There's just a lot of those pieces you got to look at. So when I look at them, from this perspective, models with low or no fees with risk protection and high sharing of savings de-aggregated, that's what you're going to see. Or, you're going to see some that have guaranteed fees and no risk protection, and they're going to have a lower sharing of savings to the aggregator. And I see people that are happy in both of them. Again, it comes back to what works best for the facility, what works best in the totality of what you think your total anticipated cost is going to be versus your potential for reward. So what questions do we ask? This is the key kind of piece here in doing that due diligence. From my perspective, there's 4 really important pieces that you want to start looking at. Let's talk about reputation. I'd start out by asking, how many years has the ACO been in existence? That doesn't mean that just because they've been in the business longer that they're better. It just means that they may have more experience. All things created equal, I'd probably lean towards somebody who's had more experience, unless as I start to find out there's bad rep that goes with that. Has that ACO been experiencing growth or decline? Are they getting more and more individuals involved and engaged over time? That's probably an indication that they're doing well. If they're declining, why? What's the cause? What's the purpose? Have they delivered shared savings? There are a couple of groups out there that have done an amazing job, in my opinion, of delivering shared savings at the facility level. And so, all things created equal, I want to work with somebody who's been a winner versus one who's still trying to become a winner or never has been a winner. I think you want to really look at those questions is interviews with current participants. I'd be looking at who's in the ACO today, and I want to talk to their leaders. I want to talk to those individual facilities, those facilities that are like me, in my market, outside my market. Find out what they like, what they don't like, what's working, what's not working. You're not going to find a perfect partner. So you're always going to find a couple things that somebody wishes was done a little differently. What you're trying to figure out here is who's the best partner, what's the best option. And then my key, and I do this in any type of thing when I'm out looking for selecting of anything, not just an ACO, is I really want to have an interview with somebody who was a participant in that ACO, but decided to go somewhere else. Because that's where you really start to learn some truths. And truths can be a positive thing. You may find out as you're going through this model of interviews that somebody left an ACO because they were looking for somebody who was more regionally focused, and this one's nationally focused. Well, you might be looking for something that's regional. That might tell you what you need to know. That might not be a bad thing to hear about a provider. It just tells you that they're not the right one for you. They may be a great ACO provider. Again, just not the one for you. Lots of things to be learned by asking those kinds of questions. The fit with the organization. And this really comes down to culture. I'm a big person on culture. Any business relationship that I'm going to be in long term has to have a culture fit. When I work with providers and facilities, there has to be a culture fit. I have to believe that we're on the same page, trying to get to the right place, and we treat things the same way. We treat people the same way. We treat our patients the same way, our staff the same way. We have the same vision of the future and things like this. This can really be a big litmus test for a lot of people. Places to get these kinds of questions besides just the meetings that you have would be looking at web pages, social media, things like that. For the most part, these organizations, when you are visiting with them, and the parties that you'll deal with are going to be on their best behavior. So I don't know if those conversations can be a selling point to say, yeah, I definitely want to jump in. But if you have a bad experience, it's probably, if that's their best behavior and you're having a bad experience, that is probably a good sign. But definitely just some things to think about in that area of culture. Culture can beat out even the best of opportunities. And then the services that are provided. And so what we're looking for here is, those services and the support. That's, to me, is the big key. That's what gives people the ability to succeed. Some of that can be, the programming around how do you do annual wellness visits. You may have to tweak your process, but they can give you good tools there. How do you do CCM visits? How do you bring in behavioral health to help drive down costs and things like that? How do you communicate to your community? How do you communicate to your staff? All of that, and really getting into best practices. Best practices can be through training. Best practices can be with cohorts. I love cohorts if you have a great leader or facilitator that can help pull the conversation out. So those can be really good. Online resources, again, do they have programming that's online? Do they have things that are available on demand, which could be some training? Do they have like a resource center for things like billing and coverage and things like that kind of help you? Because as you get into these new services around population health, there's always a lot of questions about, is it covered? How do I bill it? Is it something that goes on the UBO for? Does it go on the 1500? Is there a professional component? Is it just a technical, or is it just a technical and not a professional? How do I get paid? Is it a fee schedule? Is it a cost? What are all those different things? The more resources you can get, that's what you want to find, is what let me see your resource center. And then your data access and in data analytics. It's got to be more than a data dump. Fortunately, most places are getting better than that. I really want to know the background of the people that are developing the data. Do they understand more than just data? Do they understand healthcare? Do they understand, the clinic side? Do they understand the financial side, the billing side? Do they have any of that knowledge? Because at the end of the day, you want to take things from being data, which is that individual facts, figures, move it to information where it's a little bit more organized, structured, categorized, potentially useful at that point in time, and turn it into knowledge, where it's ideas and learning concepts, and it's synthesized, it's thought out, so you can turn it into wisdom, which is that actionable item, that piece that you can take and work with. Too often what we see is data that's on the left-hand side of this equation. It's all focused on the data. It's not focused on knowledge and something that people can use and work with. And then finally, and I know this is not the final for most people, this is the starting point for any, but what's included in pricing? And what is the price? What's extra? Am I going to feel nickel and dimed? Am I going to feel like I got a good purchase, a good value? At the end of the day, I'm looking for a value. What's my value I'm going to get out of this? And so, at the end of the day, you got to start looking at the total cost and reward assessment. You got to stack up the options that are out there as you're visiting and looking at various options, and you're going to stack them up. And they're not going to be apples to apples comparisons, because they're going to offer different things. They're going to have different twists to things, and that's not a bad thing. Options and not, provide a lot of opportunity out there. You want to look at actual hard costs, as well as what we'll term the internal soft costs. And what that soft cost is maybe I don't have to pay for something, but maybe it's because I have to take care of it with my internal staff. And one can argue that internal staff is already a sunk cost, but if they're already having a hard time getting things done, there's still that extra cost that the organization bears. And then compare that, to the risks, if there's downside risk, as well as what's the potential for reward. And at the end of the day, trying to come up with, what's that net present value of what I'm looking to get into. So it's really a balanced approach between opportunity and threat. The more you try to limit the threat, the more it's probably going to cost you in one way or another at the end of the day. But that doesn't mean it's right or wrong. And no answer fits all. So what works for you may not work for the organization, in the next community from you. It may not work for another facility that looks like you, but has different circumstances within its entity. And just because something works for you today doesn't mean that in the future it'll still be the right answer. It might be something that you need to look at a little differently. You might want to look at a different option down the road. So, the question about HIT and interoperability between sites, that's a great, I should have known John came up with this one. This is a great conversation. If you can get interoperability, that is great. I have not seen as much good interoperability as I would like to see, personally. The data that they can get is more so in the rural setting, the data they get from CMS and things like that. But if you can get interoperability on systems, that's going to be great. I've not seen a lot of great solutions there. It's got to come at some point, though. It'd be a lot easier. It would be a lot easier if you're in a small region, maybe, to get interoperability, because really you almost got to get to similar systems. And so, we can name the whole list of, usual culprits as far as, who the HIT vendors are. But in each market, there's going to be a different presence of one versus another. I can go into one market and I'm not picking a favorite or anything, but one market might be heavy Epic. The next one might be heavy Meditech. The next one might be heavy Cerner. The next one might be heavy CPSI Thrive. There's all kinds of different models out there, and they don't tend to speak well. But if you get into a market where it's a lot of similar people, you might be able to get a little bit more of that interoperability. Would I expect to see an ACO offer services individualized to rural versus urban? You could see some variation with that, just because sometimes we don't have as many of the resources available in our small rural areas because of just the limitations of expertise, as well as the fact that in most rural providers I work with, definitely people are wearing multiple hats. And so you could see some variation there. I have not probably seen as much blatantly advertised as such, but I would tend to believe that you could see definitely some things a little differently from that perspective. So again, no one size does not fit all. It'd be definitely the one thing I want to make sure everybody leaves with a little bit. So in kind of a closing here, and then I'll continue to watch for questions too. The decision to join an ACO and pick one is a difficult one. It's difficult just at the beginning points of getting your organization to understand why you go into a model that's going to reduce costs when you're already struggling for reimbursement dollars and things like that. Once you get past that and you figure out there's these upsides there, not just in shared savings, I think that's one area, but there's other things as far as volumes and getting the quality care and all the preventive things you can do locally that oftentimes we're not. That's a big chunk. Then getting to the right ACO can be a tough piece. Which one's going to fit? Again, ultimately, as I look at it, the best fit comes down to reputation. If they've done a great job in the past, they're probably going to do a great job in the future. If they're got a good name, they're probably going to have a good name. Everyone's going to stumble their feet once in a while, but that's going to happen. Fit within the organization, that's the culture piece. You want to work with somebody who has the same values that you have. Services and support provided, and that total cost reward, really a big piece you got to look at there. And at the end of the day, a lot of work and everything else. I wish everybody good luck on that challenge. I am a huge fan of the ACO model. I will not say it's perfect. It's got a long ways to go to be perfect. But there are great opportunities, and I've seen facilities do some amazing things to patients' lives, to their own financial performance, to just the overall practice of medicine. So good luck.
I do have a question, if I can ask it, Rob.
Yeah.
This is Rhonda Barkus. So just another question. And thank you again for doing this, because with the RIPT project, it's all geared towards getting hospitals and clinics prepared to go into value-based care. And so this is one of the questions that often comes up. How do I even decide? But my other question is there a resource where a hospital or clinic could go and look at kind of a shorthand as far as comparing different ACOs on different variables, or do they have to go really to every single ACO they can find and get that information? Does that make sense?
No, it makes total sense. I am not aware of a good, there's not like a consumer report. You're almost asking for like a consumer reports kind of guide. I'm not aware of one that's out there. On the flip side of that, in most markets, it's a small number of potential parties that you're looking at. Now,
Okay.
if you're in a big urban market, things like that, there might be a lot more players out there. But in several markets, when I've helped people try to find entities to talk to, especially if they're looking at it from a Medicare side of things, there's 3 or 4. And sometimes not even that many.
Okay, thank you. I think I assumed that there were a lot more out there.
Not with what I would call the real rural. You know, and there's probably a lot more out there, but they might not operate in your area because they're regional or they're state focused. But if you start thinking of it from a national perspective, I might find a couple, local, 1 or 2, and then a couple national. But there's a lot more out there. They just wouldn't play in that market. Well, I think that brings us to the conclusion then. I want to thank you again for the opportunity to get to speak with you today. If you have any questions, by all means, do follow up and let me know. And again, good luck.